Elimination Part 4, Introduction to Nursing Concepts. This is Martha Olson. We will be looking at several of the things that as nurses we implement related to elimination. The first one being the urinary catheter insertion. We catheterize for many reasons. One is not for our convenience because we don't have time or don't want to get a patient up to the bathroom. The skill is talked about on page 1071, and we will be practicing that in the intro lab. One reason that we would want to put a catheter in is the number 2 bullet for surgical procedures. The very simple fact that we want that bladder very small without urine so that it is not nicked or damaged during the surgery to the abdomen. Women going in for an emergency C-section, same reason. We want to get that bladder as small as possible so that it is not damaged. And the last bullet, that continuous or intermittent bladder irrigation, that is usually for a man that's had TURP surgery. TURP is transurethral resection of the prostate. It's to go in and roto-rooter out that prostate gland on a male that is enlarged and not allowing that urine to flow out. Box 45-7 gives indications for a cath. This is an example of sample documentation that you might see. We want to always include the size. Catheterized with the 16 French, the F is French, that's the size or the diameter of the catheter. 16 is our standard number without difficulty, meaning it went in, they didn't have a lot of pain, we didn't meet a lot of resistance. 60 milliliters of cloudy yellow urine obtained and sent to the lab. Patient continues to complain of burning on urination. I sure hope Mickey Mouse did not put that catheter in. Care of the urinary catheter then, our routine cares can be delegated to a nursing assistant as part of their cares, but we as nurses would always want to look at that catheter to make sure that it's intact, that it's not rubbing or causing trouble for that perineal area. We always want to cleanse from the perineum out. We never want to go from the catheter in because that would be introducing bacteria to that area. If we get a hole in the bag, we would need to change the bag. I've had that happen before when it got caught in the wheel of the wheelchair and put a hole in the bag, or if something else happens to that bag that would cause it to be damaged. Removal of a urinary catheter is much easier than putting it in. It's a clean technique, so you will just get clean gloves. You will get a warm wash rag and a towel to be able to cleanse that perineal area, and then you will need a 10 milliliter empty syringe so that you can deflate that balloon, pull the catheter out. I always put the catheter inside of my gloved hand and then remove my gloves so that that end of that catheter is contained. You will want to make sure that you empty the catheter before you remove it so that you have your output for that shift. And then you will want to watch for that first urine elimination that they are able to do on their own. It may take a while because when you remove that catheter, the bladder will be empty, but if they haven't voided in maybe 4 or 5 hours, then you would want a bladder scan and see if they do have a problem with urination. Some of your post-surgical patients will have difficulty because that bladder, that neurological system is still sleepy from the anesthetic, or maybe they have some loss of control to that because of a motor vehicle accident or something. Always check your orders because many of them will call for a UA to be sent down with the removal of that, just to make sure that that catheter has not caused a UTI while it's been in place. We would be most importantly thinking about when we would expect them to void on their own. A lot of that will depend on how much urine output, if they have an IV running at 125 an hour, how dehydrated they are, some of those types of things. Page 1064 gives you a pretty good idea of what we need, what we would be concerned about after that catheter is removed. Moving on then to the bowel. The administration of an enema or suppository is something that takes a lot of nursing judgment and critical thinking because there are so many things that can go wrong if we aren't doing it correctly. This is found on page 1112. We know that an enema is only given as a last resort. Some of our patients will come in and tell us that they perform an enema at home on a regular basis in order for their bowels to move. We know that can be very dangerous because that eliminates that musculature in that colon, and they then have to depend on the enema to be able to evacuate the bowel. Our types of enemas are listed there. We will be doing some practice with that in the lab as far as what type of enema would be ordered by the physician, and then as a nurse how we would prepare that for them and why it might be most appropriate. We will be doing a mind map looking at some of these different types of enemas that are given. The other one that's not up here that they do in the Fairmont Hospital is called a milk and molasses, and it's truly molasses. You go down to Hy-Vee and buy molasses and get some milk, and it's kind of a cleansing type of enema that they do at that particular hospital. We've talked a little bit already about obtaining a urine specimen. Page 1068 in Potter and Perry talks about the fact that when you have a clean voided, you give them the cup, you give them the wipe to wipe front to back, with the instructions to start voiding into the toilet and then put the cup under to catch some of the specimen. It's called a midstream, and that is because the first urine is going to be contaminated because it's coming out through that dirty part. So we want to get it when they have voided a little bit into the toilet. For the female, they need to wipe from the front to the back, and the male, they wipe in that circular motion at the tip of the penis, starting working outward and down. Our 24-hour urine specimen is talked about on page 1053. The important part of the 24-hour urine is that when it's started, you have the patient void and throw that away, and then your time starts from then on because that urine has been in the bladder before the time that that was ordered. We collect that urine for the full 24 hours, post big signs in the bathroom so if a nurse aide or somebody else takes them to the bathroom, they don't accidentally throw it away, because if one gets thrown away, you have to start all over. And then it is collected for that whole 24 hours. At the end of the 24 hours, that last urine is collected, added to, and then it's taken to lab. We have it in the bathroom on ice so that it stays cool. What it's mostly looking for is hormone levels over a 24-hour period. I had to do this. I'm in the nurses' health study for the Harvard, and they were looking at hormone levels in women my age, and this was one of the tests that they had us do. They may look for aldosterone, amylase, potassium. There's a lot of things that show the picture of the kidney over that 24-hour period of time that they would want. Removal of an impaction is not the most pleasant of nursing things that we have to do, and if I could only stress the importance of preventing an impaction. Not all of them can be prevented. You get people that come into the hospital from home and they have gotten impacted and didn't realize that it had gotten to this serious of a point. On page 1107, box 46.8, it talks about the removal of the impaction. The most important thing is that it can cause a vagal response. That 10th nerve then can be impacted and cause the heart rate to decrease significantly. That vagal response can be from an enema, it can be from a suppository, or a removal of fecal impaction. Make sure that you lubricate your finger well before you go in, and then try to remove that hard impacted BM for that person. Oftentimes just getting part of it out, then if you get them up to the commode, they are able to move the rest of it out on their own. You have to have a doctor's order to do this, and you need to watch that heart rate the whole time you are doing that. We will be looking at the medications in class, doing some activities on these. They're very important. Many of them will be asked about on board, so we want to make sure you have a good handle of the meds. Many of them are over the counter, and so people are taking them at home without a lot of direction or education. Our cathartics and laxatives then promote the bowel evacuation for somebody that's constipated. A suppository can either help with constipation, or we give a lot of medications via the rectal route. A hospice patient, we can give them suppositories because they're unable to swallow and they don't have an IV. And then our enemas again promote defecation by promoting peristalsis. So when looking at our evaluation of this last unit, Regular pain-free defecation and urination is what we want. We're always looking at what were the results. After I put in a catheter, how much urine came out right away? After I removed the catheter, how long did it take them to be able to have the urge and to get up and urinate? Is the client able to demonstrate that they know what's going on with their elimination patterns? Because if they go home, would they know what signs and symptoms are serious and they need to report? So we evaluate every time we give a suppository. You should always come back and say, you know, suppository given at 1400, able to have a large brown bowel movement at 1730. And then start looking at what caused them to be constipated. Can we add prunes to their diet, prune juice, fruit juice, ambulating, more water, to try to prevent that from happening. These are the terms that you will need to know for this unit. Hopefully we'll have time to play a game of bingo or something using these, but as you look through them, if there's any of them that you aren't familiar with, you will want to look them up and discuss them. Special considerations as we look at this unit. With our pediatric population, we know that there are a lot of things that are very different for pediatrics. They will not probably have the 30 milliliters of urine output as adults do, so we base it off of their weight and their age. The first consideration with pediatrics is that first bowel movement and urine output that a newborn has in the newborn nursery, because we want to make sure that there are no malformations to the kidneys or the bowel that would prevent that. The stool of a pediatric or a newborn baby is very different based on if they're breastfed or bottle fed, and oftentimes they're yellow and seedy and they have several bowel movements per day, and that's very normal for a newborn. Your pediatric population, we also worry about the potty training and the fact that, you know, are they able to be potty trained by the time they're 3 or 4 years of age, and that normal growth and development. In our older adults, we have things like nocturia that we have to consider, you know, taking diuretics too late in the day and they're up voiding at night. Are they standing too quickly to get to the bathroom because they have urge condition and they maybe fall because of orthostatic hypotension? So with both ends of the spectrum, we do have considerations. In the middle, we have things like Crohn's disease, irritable bowel that we have to consider. Some considerations for not using a bedpan. You can see a typical bedpan here. There is a different one that's much flatter called a fracture pan, and that would be used for a patient that's had a hip surgery, and it's much flatter and easier to lie on. There are tricks to using a bedpan without spilling them. One is when you roll them on and off of the bedpan to hold on to the bedpan so it doesn't roll with the patient. And then when you set that on the floor, don't step in it. It's very easy to be doing your peri-cares and step into that bedpan. So you have to be very careful. It's just kind of one of those tricks that you learn through a lot of good practice. With our pediatric, remember, many of them will have regression of toilet training if they're hospitalized, and they will go back to wearing a diaper. This stresses parents out, but you just need to reassure them that once this child is well and feeling well and back to their home with their routine, they probably will go back to the level of potty training that they were at before they came in. Before age 2 to 3, their neuromuscular system is not functioning or fully developed, and so it's not possible for some children before that age to be potty trained, and a lot of parents stress about that because they think they should be out of diapers by the age of 2, and they become very controlling trying to get that child potty trained. With our older adult, then again, incontinency is not a normal part of aging, but it is something with some of the elderly we have to deal with. We also have incontinency in middle-aged people as well. When we look at decreased mobility, that decreases their peristalsis, predisposes them to constipation. They may not get up and void as often because of arthritis and mobility issues getting them into the bathroom. So think of problem solving. Do they have a bed, or do they have a bedside commode that possibly they could pivot into much easier? Many of your patients with congestive heart failure have diuretics that they use to take that pressure, that volume off of the heart. So there are a lot of considerations that we have with this age. Again, our older adults, that prostate change to the male can become significant. That ends our elimination unit. I hope you've enjoyed these, and I look forward to doing some activities in class. Thank you.